going to talk about sort of, I guess, access, equity, and continuity, which is kind of, we've kind of covered a few things, but you've talked about, how we can offer help to the disadvantaged or the complex patients and not, still offer them bulk billing if we have enough money in our kitty to do that. Now, the cost and timeliness, the fees, the long waits, and limited public or specialist services, the delay in care because the waiting times are blowing out. But even before we get there, I think personally, I don't know how you feel, that even the communication between tertiary and primary care is appalling. We never get timely discharge summaries. Even when a patient goes to ED, we go and look up. I don't know what you do in Victoria, but I know in Queensland, I look up the viewer on Queensland Health Portal to see what happened to my patient. Did they send them home or did they admit them? And what's going on if I'm worried about a patient. I don't get any stuff. But the patient fronts up on my practice and says, "Oh, you got a letter about me. Now tell me what happened and what do I need to do?" And I go, "There is no letter." You know, so there's a really like very poor sort of communication and a lot of dumping back to us, I think, at the end of the day. What do you think can be done in this area to help bridge this gap and improve patient care and make it more, expedient and timely?
Yeah, look, I've had the experience of being involved in the Victorian health system on system reforms over the last 6 years. One was a project at looking at timely clinical handovers. I don't like the term discharge summary because it just means get out of my hospital. I don't
Yeah, that's true.
like
It's
the
very
clinical handover. Also, I was involved in the planned surgery reform in Victoria, and also now the specialist outpatients reform in Victoria. So these themes I'm very familiar with. And what I recognise is that good reform does need investment. Certainly in the state of Victoria, we have limited funds to implement a lot of the fantastic innovations and ideas I witnessed being put on the table. But I have, and I'm custodian of those ideas, and I know that there are things that you can do to improve this. But it really comes down to political will and to a communication with the hospitals that you need to be meeting a standard for clinical handover. And we need to signal that it is the heads of units and the consultants in these units that should have responsibility for making sure that that handover is done and that junior staff are trained and supported to do them. Because it is one of the most important documents and it is a bridge between one arena and the other. And without it, there is serious safety issues that can happen to those patients. The other thing that I find really difficult to accept is that a recent study that's been done in New Zealand suggests that GPs are spending 31% of their time in non-face-to-face administrative tasks. Now, that is worse than the NHS. The NHS GPs there are spending 25% of their time on non-patient facing tasks. Yeah, well, in Australia and New Zealand, we're now at 31%. So first of all, that's all unbillable time. So 1/3 of a GP's time, just like that, is totally unremunerated. But it just tells me that we're spending so much time compensating for the failures of the system. And again, I think that not only is it a waste of our time and disrespectful of our time, but it indicates to me that there is a risk peppered all over the system that needs to be addressed because we have to provide a safe health system for people so the harm doesn't come to them. Now, in the NHS, we know that 3 in 10 patients have got serious harm occurs to them as a result of interacting with the NHS or the NHS failing to help them. And I'm actually really concerned that that's going to become a reality in our country.
Mhm. Yes, so true. And that's very sad. That would be very, very tragic if that happened. So, I mean, someone actually put in the Q&A tab. I know this is a very provocative question, but, how about a live debate between yourself, Anita, and Margaret Fore on the ABC to get the GP reputation back on track? Would you be?
Oh, I'd be delighted.
Oh,
Do you know what? I have, I'm not, look, we've all got to be sensible,
yeah.
diplomatic, intelligent and sophisticated when we do our advocacy. But I mean, Margaret Foe's PhD was critiqued in great detail at the time, including by a team at the college that looked into it. And I can say with confidence that the conclusions that were drawn from that document did not represent the data, and it certainly didn't represent any power within that data to extrapolate to the extent that she did. So, I mean, there would be points that I'd be very happy to make.
Yeah. And on another note, you mentioned about how patients can be our biggest advocates and be a strong voice for us to make the government sit up and listen. Someone's asked, how do you propose that we engage patients and the general public to bring them onto our side and kind of give us traction?
So actually, there was a really interesting study that was done in the 2000s or 2010s. I can't remember now. That said that while in general, the public might say, "Look, GPs, I don't know about GPs," but
Yeah.
when you talk about their GP and their clinic, they're like,
Yeah.
"But my GP is awesome,
Yeah.
and my clinic is the
Yeah.
bomb," right?
Yeah.
And so there is an enormous opportunity in that to say to patients, not can you go to bat for
Mm.
GPs you've never met before in a state that you don't visit very often, but
Mm.
patients can be recruited to defend their
Mm.
GP and their clinic because they know from lived experience what the value is and what that environment provides to them in terms of health and well-being. So there is an opportunity there. Look, we need to be unified as a community. Probably
Yeah.
the single biggest saboteur of all of our efforts so far in advocacy has been our own internal division. We are a
Yeah.
broad church with very broad politics, very
Yeah.
disparate politics.
Yeah.
But I would put it to everyone that actually in the next 2 years, we really need to decide, details aside,
Yeah.
we need to all come together because we are going to be so defunded and devalued that our existence will change immutably.
Yeah.
And once we're on the other side of that, we will be repenting at leisure. So
Mm.
my intent is to ask our community to come together, even if we don't see eye to eye on every
Mhm.
political
Yeah.
point. Because we must do that because the government, I think, sees it as a win when we behave in a divisive manner.
We are going to be a toothless tiger if we don't band together. And look at every other group or college or guild. How do you think they have so much power?
Yeah.
We need to really, like you said, band together and drive a big force. Let's move to the topic of urgent care clinics.
Mm.
A lot of funding. It was like the super clinics, the white elephants that
Mm.
the government had done many years ago. Now we have the urgent care clinics. We know that the average cost of a visit to the urgent care clinic is multiples of a GP visit, right?
Mm.
If I do get a discharge summary or a letter, sorry, from them, if I don't always get it, it'll always tell me to then do follow-ups and do something else. They haven't actually closed the loop. So
Mm.
how are we saving money and how is it serving our patients better?
Look, the fact is that I don't think that urgent care clinics at this stage, when you look at them in an aggregated manner, have done much at all to relieve the burden on emergency departments. And many people may have read the article in The Age where Sarah Whitelaw from the AMA was interviewed about that, and also GPs, fantastic GPs from our community were interviewed. Reflecting that. Now, I do recognise and I respect and I reflect that there are some urgent care clinics around our country that GPs are working in that deliver enormous value and to their communities, and they are working very, very hard, and there are genuinely a need for them to be there, particularly in areas where there aren't hospitals nearby, and I've witnessed that firsthand. But I do know that in the main, urgent care clinics, particularly the tranche that have been rolled out by the federal government recently, is a politically motivated, and it does concern me deeply because I know that it's not having the impact on emergency departments that it's purported to. The reason why I'm so concerned is that it's being demonstrated that the government is willing to disrupt the whole of the general practice industry by going into direct competition with
Yes.
mum and dad, everyday GP owners, and saying, well, we have got unlimited funds. We've got an entire health system budget that we can use when we're going to competition with you. We're willing to spend between $250 and $300 a service so that people can have free care there. whereas the GP down the road is using the paltry, $60 maximum to try and do the same thing, and has to charge privately if they're going to use disposables and dressings in their treatment room. So
Yeah.
the fact that the government is willing to put that much pressure and interfere in the industry in that way bothers me deeply, because it means that they're quite happy to apply so much pressure on the clinics as to force them to close, or to shame them into bulk billing, which we know will force many of them to close. So I do know that Mark Butler has been asking for frank and fearless feedback about urgent care clinics, and I would want to take the opportunity to have that conversation, but particularly to say why is the government wanting to apply so much pressure on general practice, which is holding up the health
Yeah.
system and potentially send all of these businesses into insolvency? What would motivate
Yes.
a
What are they going to
government
achieve?
to
Exactly.
destroy those businesses and those health services and leave patches and deserts
Yeah.
all over the country, like we've seen in rural areas in WA, for example, and elsewhere?
Yeah.
Why would you want to do that? If you are the responsible custodian of our health system, why do you feel it's reasonable to allow these businesses to close?
So, what do you propose for the disadvantaged, segments? For example, you've touched upon the rural and regional Australians who do miss out because there's not enough services there, GPs and specialist services. And maybe let's talk about the First Nations people as well who don't have access, same access. It's not an equitable sort of, access to healthcare services. So, what do you have in mind to help that segment?
So similar to the comments that I made about my belief that community health and ARCHOs have a very important role
Mhm.
to play for vulnerable populations, but I also believe that vulnerable populations should have access to a particular funding structure that essentially fills the gap for them, and so particularly in recognition that they may need more care, or that they may need care coordination, etc. I think that a person who comes from a socioeconomically vulnerable group should have access to funding system that boosts them, that recognises that they're not going to be able to pay the gap. Now, inside of a community health centre or an ARCHO, that would be fantastic, because that can be a space where the fee-for-service has less of a role to play. But also, I think that we can recognise that people with particular comorbidities, mental health, living with whatever disadvantage, they should be able to trigger off additional payments that reflect that complexity, and that relieve them from having to pay a gap, but also recognise that the practice is going to have to spend substantially more time caring for them and then also coordinating the care. One of the things that I've said, Anita, also is that we've been told by the government that the multidisciplinary teams are the future of general practice. And we would be able to do so much if we had the right personnel in our general practices, like a social worker, for example, looking after people who are vulnerable and doing a lot of the social work that falls on the shoulders of GPs. But despite years of advocacy, we're yet to see the whip increase so that we can actually employ people that can do that work. So my question is, if we really are serious about establishing multidisciplinary teams in Australia, why are we being hampered by not getting the
Mhm.
WIPs and PIPs, actually, that rewards general practice for saying, yeah, I'm going to take this to heart, I'm going to set one up, and I'm going to set one up in a way that reflects the population that I'm treating?
So there was a question about, in the previous theme when we were talking about registrar training and placements and, capacity. I think someone asked a question. I couldn't quite understand the exact question, but it was about any chance of changing the role about uptake of registrars in the new practice and not limiting it to current existing ones. So I guess meaning opening the door to many more practices to take registrars in. I know the college has certain sort of restrictions, how many per supervisor and what qualifications the supervisor needs to have. Um, but is the college going to look at a different model of having more practices be able to invite registrars into the practice?
Yeah, this is an absolute priority and a focus, and this work is already underway. We recognise that we need more practices and more supervisors if we are to meet the needs of training for the future. Look, it's a vexed issue because sometimes in response to the fact that things do go wrong, unfortunately, and registrars have had experiences that are exploitative or unsafe, for example, we recognise that we need to have a standard for accreditation of training practices, and we need to have a universal standard in terms of quality of teaching and safety and appropriate supervision, because we have heeded the feedback and the response and the experience of registrars who have told us that in some environments things have gone wrong and things have happened. And so in respect of those experiences and the need to act, the college has said, look, we need a universal standard and we need everyone to rise to that standard.
Yeah.
Now, that can cause some controversy because where there is a standard for quality and safety and supervision, then there is effort that's required to meet that standard. But we do believe that safety and very positive and well supported experiences are very necessary. The well-being and the experience of registrars is a huge priority. But there will be change management that's required as we get people to understand what is the purpose of these standards and how do you get accredited. And I think the college can do more to really try and help people understand what's required. The requirement to be a fellow, to have fellowed in order to supervise, that will not change. And I have spoken to people who do believe that it is reasonable that if you are teaching the fellowship, you do need to have fellowed yourself. But I do recognise that in some instances that has caused frustration.
And I know there were 1 or 2 years where there was fewer applicants and more practices offering, to positions, so it became a bit of a scramble, and they could only allocate one per practice. It was painful.